Hello.
It works.
Okay, well, I would just like to welcome everyone to our webinar that we're running this afternoon. My name is Karen Bolte, and I'm the manager of the Goulburn Rural Health Program and also the Goulburn Valley Regional Training Hub with the Department of Rural Health at the University of Melbourne. Yes, it is a bit of a mouthful. Before we start, though, I would like to acknowledge the traditional owners on the lands on which this webinar is being recorded and streamed. We acknowledge their elders past, present and emerging, whose cultures and customs are nurture and continue to have nurtured and continue to nurture these lands. Before we get talking to our keynote speaker, I would just like to cover some housekeeping rules. If you could change the view on your computer on the top right-hand corner to speaker view, and then you'll be able to see our panelists. And there'll be an opportunity to ask questions through the Q&A icon at the bottom of your screen. And we will attempt to get through as many of your questions as possible. So I'd really like to welcome and to introduce Dr. Arnold Stroobach, the University of Melbourne Department of Rural Health. We're really excited to bring you this webinar presented by Arnold. He'll provide an overview of the Netherlands a model of healthcare that has been developed in the Netherlands, the Buurtzorg model. Buurtzorg is a pioneering healthcare organisation established more than 13 years ago with a holistic model of care that has revolutionised community care in the Netherlands. The organisation focuses on client satisfaction, which has inspired interest and collaboration from all over the world. I think there's more than 25 countries now involved. Is that correct, Arnold?
That's correct. Yep.
And in this webinar, Arnold is the founding partner for Buurtzorg in Australia, and so he will talk about adapting the model to our context and discuss the progression of the model within our community. So Arnold, I welcome you to our webinar. Thank you very much for taking the time to speak with us.
Yeah, thank you very much for having me here. Welcome everyone. I will switch on my presentation and I'll leave Amsterdam for a while. Here we are. What I like to do this afternoon is touch briefly about Buurtzorg history, a Buurtzorg model itself, and then what we're doing in Buurtzorg. We have Buurtzorg in Australia. Now something disappeared to the background. Here we are, back again. What's interestingly, what I see happening here at the moment is that a lot of changes in healthcare. So introduction of the NDIS, my aged care, things went from state to federal, quite significant changes, approaches changes. And in the 90s we went through a similar period in the Netherlands. Unfortunately, it didn't pan out very well. So a couple of things: fragmentation of cure, care, supported prevention. Things became siloed. Also, the wrong drivers. So delivering much care against low costs. Also, a belief that if you hire cheaper people, that the system becomes cheaper. Now we found out in healthcare it's the other way around. We had big capacity problems. The demand was growing. So the demand was going up, but the costs were even, the curve was even steeper. And it became very, very messy. And at that moment, there were a couple of people among Jos de Blok, and people know a little bit about Buurtzorg. They heard about him. He's his founding founder and the CEO of Buurtzorg worldwide and in the Netherlands. They said, right, we don't know what to improve, we don't know what to do, let's just line in the sand and we start a new organization back to what we think are important principles, where the starting point is someone who needs care and support and the person who can provide it. And we're talking about home care situations, so not hospitals and those kind of things. So pure on home care, and it just started. And they tried to make arrangement with the insurance companies, and that it went pretty well. But from the perspective of the clients, it was such a relief that they were registered nurses again in the neighborhood, and there were things happening, and it went like word of mouth went very quickly. So what did they do? They took basically a bit of an existing model developed in the 70s in the Netherlands and made it more suitable for the healthcare system, and it became the Buurtzorg model. So working in autonomous teams, maximum 12 care workers or support workers, and working in a neighborhood. And if you look at the word Buurtzorg, it's a Dutch word. Buurt is the Dutch word for neighborhood, but also community. It's an overlay, it's not a real English translation for that. And zorg is a Dutch word for care. And buurt is very important in the Dutch society because everyone lives in their little environment where everyone knows each other. That's what you try to do, and you know the local IGA, you know the local GP. It's the give and take situation. And so buurt is a very important social structure in the Netherlands. So when they started, immediately everyone understood where they stood for. Care in their buurt, neighborhood. So self-managed was an important thing. So the teams are responsible for the whole side of the care and support. And you organize it, you're responsible for it, and you start to finish the whole process. And instead of a head office with structure down and reporting up, it became a back office. And it's not only semantic, but it's really supporting the front line. So the clients of the back office are the teams at the front line. And of course you have compliances and management have responsibilities. That doesn't change anything, whether it's Australia or whether it's in the Netherlands. But what we try to do is the decision making is close where the action is. And that is where the clients or the consumers in my aged care or in NGS participants and the care worker or the support worker, there's where it all happens. And it went very quickly. So it's now over 15,000 people in the Netherlands, and we expanded over 25 countries now also in Australia. So I will address a couple of key elements because it's I can talk about it for hours and I have half an hour. But a very important thing, trust instead of control, and that's the most important element of the whole Buurtzorg model, and also the hardest one. We really have to putting trust into people. And our experience is, especially in healthcare, in selecting the right people too, if you give them the trust, people, they take it seriously instead of trying to control, because they're always trying ways around it. But it's a very important element of our model. Self-management, this is the most visible bit from, visible side of Buurtzorg. A lot of people heard about Buurtzorg, we have something with self-managed teams. Yeah, that's true, maximum 12 people, but also a bit we call the entrepreneurial or the entrepreneurial spirit. You don't have to be an entrepreneur, but it's a bit like running as a team your own shop. You have your responsibilities to do the right thing and do it safely. So it's not for everyone. We found out in Netherlands and in some countries it's a little bit different, but in general about 80% is very happy with the model and some 20% struggle with that. So it's a big group who likes it. Sorry. Yeah, humanity above bureaucracy. Humane values are the driver. So especially we're in healthcare, we're dealing not with baking tiles or bricks. We're talking about human life, human beings, and quality of life, and interfacing between people and people. And so human values should be the core driver of the service we provide. And that's also care worker or support worker and client. Who's more important? client-centered care, person-centered care. But if you don't have a happy provider, a happy care worker or support worker, how can they really do a good job with the one who needs the care and support? So Joseph Bloch says it's a very irrelevant discussion, both on an equally number one position. So if you're a happy care worker, you have a happy client. And that is part of the model to discuss that. We call team health. It's in the interest of the client to have an happy, engaged person. Because we're talking about home care, and that means the moment the client opens the door, their reality is one which is the other side of the door. Is that someone who is engaged, happy to be in the job they do, knowing the client, having a relationship with the client is different. Is someone is there who doesn't want to be there, doesn't know you, has a list what to do, and off they go again. And so that is, again, the humane values are important, and that will make a difference. The other thing, also known about no management, is very small management. There is always some management. That's in any country is a requirement. But coaches, these are the people who really drive helping the organization work. And coaches are safe people, we call this, not a line management. They're not the answer man. They're not telling the teams what to do and how to do it. They try to facilitate that the teams find their own answers and solutions. Very important part of the model. Another important part is, again, the small and serving back office. The back office is not a line function with the teams. The clients of the teams of the back office are the teams. That's really different than a head office. And it has to do with how things happen, how they communicate, the relationship between the teams and the back office. And there's also, when that goes wrong, the empowerment of the teams go very quickly out of the window. So it's an important element of the model. The other thing is we call solution driven, and we call a solution driven method of interaction. You have to learn from your mistakes, but don't forget to find a solution. Because often when an incident happens and things and a lot of things suddenly start to happen, process, procedures, and meanwhile sometimes the client is forgotten there to what about me? So finding solutions instead of keeping in a problem domain. So it's a very positive, looking forward culture in the Buurtzorg model, which really is one of the other important drivers of the success factors. And focus on relationships, warming and meaningful relationships. Australia has embraced also the person-centered care, where the core is building up relationships. Understand from both sides who are you, what is important. For everyone is different, and every day is different again. You need those relationships to be able to do the right thing and also to do the thing safely. Human scale, that's part of the model. Your neighborhood scale. Keep things small, because if you have a relatively small team in a relatively small area, the neighborhood, a lot of things goes automatically because you just know. It's easier for the relationships, it's easier for reachability, and also everyone takes part of that. And we live in 2021, so let's use ICT systems as much as we can to facilitate the teams, but also the communication and simple things like rostering, making sure we can invoice and upload to NDIS, invoice to my aged care, and the compliancy side of things, timesheet, those kind of, you can automate as much as you can. Right, a couple of slogans. This is an important one. First coffee, then care. And what we mean with that is Firstly, we drink a lot of coffee in Holland, like most of the Northern European countries. But for us, coffee symbolized sit down and try to get to know each other. When it's a new relationship, so it's a starting point. Who are you? What's important? What's your background? Your life story? A bit from yourself. Who are you? So important things. Start building up a relationship. But every time you go to your client, just having that moment. Just don't start doing stuff immediately. Just take your time. Have some quality time with the person, and of course relationships have to continue to develop, and it's not something you can roster. It's not alright. I have to do this, I have to do that. Oh yeah, I have 6 minutes for building up a relationship. How are you today? It doesn't work like that. But you have to give yourself time to do that. The other thing, keep it small, keep it simple. So it's again neighborhood teams, but it's so hard to keep things simple. And one of the drives is also looking at what they did from day one. When it was very small, there were like 5 people, and whatever they created in their model, in their operations and organization, was to think, all right, say if we were with 10,000 people, would it still work? And if not, let's not do it. Try to find other ways. And also go back into, there's a lot of legislation around, as well as in Holland as in Australia, and a lot of things we interpret it in a certain way, we do certain things, so now we have to do this, we have to do that, we have the policies and procedures and safeguards and the risk matrix and things. But if you really look into the legislation and frameworks, often you can see, no, that's not what they meant. And so we often go back to what's really meant, what I want to achieve. And there are lots of people in departments who know lots about things, so they're happy to talk about it with you, and you find often different solutions to make it simpler for your organization and better scalable. So you will hear a lot when you deal with Buurtzorg. First coffee, then care, and keep it small, keep it simple. It's in the mornings when I enter my office, I run first to the coffee machine, and then no, first coffee than anything else. All right, back to the back office. You see here a picture of the Buurtzorg head office. We got a lot of international visitors, and they know, right, it's over 15,000 people in the Netherlands, in 25 countries, thousands of people international. And you're going now to the head office, and you see this building. It's an unsumptuous building on an industrial area. When you enter, it's a small reception, very nice, very homely, 2 dogs roaming around, and it's a very serene place where I think 51 people at the moment, mostly part-time, so 37 FTE work there, and they do basically cover the whole organization in the Netherlands and internationally. And that's, I think, the moment people go there and walk around, they start realizing what it really means, and that you can have a small group with people facilitating and a very well-run organization. And we see it in every country, etc. It's not possible because you need management things and layers and coordinators of coordinators and managers of managers who coordinate coordinators. We found out it's not necessary. There are different ways to do that. And the moment you enter this building, you realize that it's not a marketing story. It is true. It really works. But what do they do? Yeah, the inevitable bureaucracy. Yeah, you have always something. You have to be compliant. You have the ATOs. You have the finance reporting. And the basic task is to make sure that the care is charged, and that you get the income, and the staff are paid correctly. In Holland also we have all kinds of awards, similar to in Australia. Make sure that's all done correctly, and of course the compliancy. And I think it's a little bit lower now. But say it's 8% overhead, that's it. And what it says is that from the dollar, in Holland the euro, that's meant for basically for the service for the client, 92 cents ends up over there and not at the head office. And that is an important element. It's not the driver, but it gives you an opportunity to do things different and give the client a better quality of care and support and a bit different experience. Now I mentioned a couple of things. So the back office, the clients of the back office is the front line. There's no hierarchy between the back office and the front line. It's just discussions, different points of views, and different expertise. And the supportive is consultative, is education, a lot of training. So if the systems are not, the data quality is of course very important. If the timesheets are incorrect or not in line with the care notes, for example, that the charges are differently than all those things. That's the responsibility for the teams, and the safety net is in the back office. And if they see things happening that are, well, not correct or there are omissions, it's not about telling them off, but apparently you have to train or have different discussions. So that's a different approach. So it informs, inquires, and consults. And but very important, the front line defines the dynamics, and the back office should follow this as much as they can, without for incident management things like, all right, if it's serious, within 24 hours or 4 hours, if all those things. You have also in the Netherlands, there are always external factors that defines the actions of an organization. But in general, the whole rhythm is defined by the front line. And in Holland we have over 1,000 teams, and every team is different a bit. But the art of the back office is to follow that. So not to say, right, this is how I want it, when I want it. That's not the role of the back office. So if you look at the clusters, so you have frontline, the teams, you have coaches, you have the back office, and you have the management directors. In Holland there are 2 directors, that is Jos de Blok and you have Gonnie. And that's it. And if you asked Jos, right, all the things what ends up at your table as a management that must keep you busy. Oh, I said, if that were my job only, that would be fantastic, because I have to do perhaps 7 or 8 times a year I have to do something. In other words, almost everything. So of the 15,000 people, the issues, conflicts, the incidents are all resolved by the front line with help of the coaches and the back office. So it's really robust. And the coach is also not a line function. So the only line function basically is between the management and directors and the rest of the 2 or 3 bubbles. But that's it. It's a very autonomous model. I love this picture because it gives a bit of an idea how an organization looks like. All the green, that is the front line, and the back office is the yellow stripe to the right. Perhaps I'm a bit inside. Well, let's see whether. Oh, you can't see it, I think. That's unfortunate. Oh, no, well, not sure why it's cut off. But on the side you see a little line of the back office, and then the coaches are 21 coaches at the moment, and two directors. No, sorry about this slide that didn't pick that up. All right, organization-wise, how it looks like, so low overhead, and why is that important? Besides, of course, the financial side of things, but most of the dollar ends up with the client. Room for hiring better educated staff, and room for lifelong learning, training, education. A lot of money is spent into training and education. So the better qualified, educated, trained staff you have, the better it is for the system. And the system not only for your organization but for wider things. Also, we work with permanent staff. Teams are the cornerstone of the whole model. So you need a solid team that knows each other. And when they begin, they're a bit new to each other, and then there's a crisis, and then it's always interesting to see how they survive the first crisis, and you should come out stronger than that. So you start to know each other a little bit better, the strengths and weaknesses. But if it's come and go, then you won't get there. So we always compare it with a sporting team. So if you have a very talented player in your midst, and the player knows perhaps he or she is the best, and the rest knows it too, but it doesn't mean you can't without each other. It's still this team building, and that is very important for the model, and yeah, it's also two-way street. So permanent staff, commitment from both sides. That's good for the continuity of care and support. Also, lower hiring and recruitment costs. There's a low turnover in the Netherlands, and internationally we see the same things. At the back office it's completely a low turnover. I think over the last 40 years we exist 1 person left in the back office, and in general we're around 2% turnover in the organization. So it's really low. So costs is neglectable for that. And again, it's about knowing each other. The neighborhood knows the team, and the team knows the neighborhood. So you try to have this stability as much as you can. So quickly over about teams. So what do the teams do? Basically the what and how is decided by the teams. They make the decisions, own decision making. The management stays responsible for the outcomes. And also it's Jos calls it the management of doing nothing. So it's try to not to intervene, to let go, to have the trust that the teams know what they're doing, and collectively they use the 12 collective brains to resolve the situation and provide the best care and support that's possible within your team. And therefore it's good that we don't know exactly what's going on. It's fine. So that is something people have to get used to. Control, if that's your mode of operandi, then this is hard to do, but you just have to let go. And compliance, yes, we have that. We have that everywhere in the world, and Australia is pretty strong on compliance, but it's not that different. So you can set it up in such a way that you're compliant, you know what to do, and then training and education comes in again in the team. So it's not only people at the head office would know how things work. Now everyone can understand and learn things. Yeah, the results from day one, they really haven't changed. Patient satisfaction, client satisfaction is high, always above 9. Employee satisfaction similar, and been awarded 5 times the best employer of the year, winning from organizations like Shell, Unilever, Philips, and those kind of big organizations. When Buurtzorg the first time became number 1, it was the first time a healthcare provider was the best employer of the year in the Netherlands. Never been happening before. All right, we go a little bit closer in the Buurtzorg model. We talked about the equally number 1 position between the client and the care worker or the support worker. We call the team health. The team have to be healthy, and if they're stretched too much because of too many clients, that's not good. So you have to resolve that, or you don't want to tell no to a client, but there are other ways to resolve that, but not a solution to take another one, because then the team health is compromised, which is not good for the client. At the same time, the third side is sustainability, and that's the dollar, but also the compliancy side of things. So if the moment you lose your My Aged Care or your NDIS license, yeah, then you're probably in trouble in Australia. Yeah. Also, if you over deliver or you can't claim the work, charge of work you've been doing, then yeah, you don't have an organization either. But sustainability, the compliancy is not the driver. The driver is the client-team interface that will drive. But you have to balance. It's an equilibrium the whole thing. And that's where we have all those discussions internally in a very efficient way. For example, every team has a dashboard, so they get weekly a result about sustainability. Some elements are productivity. It's pretty high for a team. In general, we're lower than that, but every team has a certain percentage, say 30%. They can, and for the therapist, they have 40% non-billable time, and it can be for training, for spending time with the family and support network, but also, for example, giving presentations at the police station, talking about Alzheimer. That's right, this is what's happening in the neighborhood. Don't arrest them, bring them home. So all those things that you can't charge NDIS or my aged care for that, but it's important in the whole model of community care. But also they can see what, if they've been meeting too much or too long, or that is right, we're going out of balance, we should change some tech. So it's good that there's more information. This is just one of the dashboards we have. It's almost real time, but it's the moment the teams can make decisions, the decision making is done by the teams. That means they also need to have the information. Otherwise, it's hard to make decisions. So the whole team, everyone has access to the information what's required from them. And there's the privacy rules, of course, and also no requirement that you see the clients of the other teams. It's all sorted. It's all safe, sound, and robust. But for the teams themselves, they can see what they're doing, and they'll see also the results of their the way how they do things. One element we call informal roles. Every team has some informal roles because you don't have a big head office doing stuff. So those informal roles are rotating. So you do it for 3 to 6 months, and then someone else takes over. For example, rostering. Most people don't like rostering, but if you've never done rostering before, you can't understand how difficult it can be. Although we have a very nice system to do that, but still it's not easy. And the moment you have to do it yourself for 3 months, you think, all right, that's a bit more difficult than I thought it was. And also how the team members perhaps respond to you, and they think, all right, I was doing the same thing. So it gives that better understanding of those elements, and because it rotates, everyone knows they get through it once and again. So it all elevates the quality of the team levels about system knowledge, about for example, advisory reporter. There's one who communicates with the back office, so they see what kind of questions come through. It monitors also team productivities, are care plans running out or not, those kind of things, data quality. But also like a mentor, some new people coming in, the mentor takes the person under the wings and make them feel home and also get used to the team's dynamics. So those informal roles in general cost about 1.5 hours a week per role, so it's not overly now to 1.5 hour, and therefore it works very well. Well, I just said it. So it is a quality, respect, joint responsibility, and it is what it does. You don't have little kingdoms. So if someone does the rostering forever, then you perhaps you see it happening everywhere, right? I'm rostering. You were not very nice to me last week. You get a shit roster next week. And so you should try to avoid, because next time it's the other way around. You're not rostering, someone else doing it. So you get all those equality and filtering out of non behavior you don't want in your team. It's very, very clever, and it elevates the knowledge and the skill set, but also it strengthens the team dynamics. Quickly about the role of the coach. Again, instead of managers, we have the coach. They're also not a line responsibility. They're always safe. So it's safe people to talk to. And they're also very important in training side of things, helping training new teams, get them up and started. Together with we have an educated trainer in here in Australia. Together they work to make sure that the knowledge is disseminated. Also we get what kind of issues, because we're pretty new over here, issue comes from the front line. What I'll do. Status of the Buurtzorg in Australia. A little bit of a history. I think it was 2015 that NDS, Geelong, went visiting Buurtzorg in the Netherlands, and they expressed interest in the model. So there was, from that moment onwards, there was some back and forth between Buurtzorg and the Netherlands. There were workshops in Australia giving keynotes. Jos Blok went a couple of times over, and that culminated in October 2017. That was decided, all right, let's set up shop in Australia. So April 2018, that was the official start of Buurtzorg in Australia, but basically advisory services only. So we were working with NDS. We were working with existing organizations who were interested in a Buurtzorg way of working. We gave keynotes in forum, convention, all kind of things happening, but in general, advisory service about the Buurtzorg model. Also, we were, you can't copy paste a Dutch model into an Australian setting, so how would it work in Australia to be compliant and that it works in the Australian context, that the work that happened at the same time. In January 2019 was the first client organization, new organization, who started from scratch in remote Queensland in a Buurtzorg way of working. So we and strategic partners, we still being the back office of this organization, so we provide our back office of service to this organization, and we set up remote Queensland care provision for this organization. That was also for us new, because they asked, would it work in remote areas? And we think, yeah, we think so. But coming from the Netherlands, we're smaller than Tasmania, and the 17.5 million people. What for Netherlands is remote, that's suburban in Australian context. So we don't have that experience, but theoretically we would expect it should work, because you don't need infrastructure. You just need people who can do the actual work, and the infrastructure, the back office can be anywhere. In this case, even in West Australia. So I will tell more about it more in the next sheet. But that was started in 2019. In Adelaide, we had a similar experience 2020. So there's more around Adelaide, but also some more semi-remote areas. So we're starting the similar thing over there. In September 2020, we started as Buurtzorg, as a care provider in Australia, in West Australia and in Queensland at this moment. And we call it neighbourhood care. So translated. Business to business for advisory, it's a Buurtzorg model, but for the people who deal with that, Buurtzorg is just a bit of a fancy name and uncommon and non-English name. So we decided to translate it to what gets close to it, neighbourhood care. Because of the NDIS start, because they expressed interest, we started with NDIS. And at the moment we're making ourselves ready for my aged care for the next registration. But at the moment we do fee-for-service aged care too. Oh, yeah, here it goes. So some experience about remote, more remote areas, communities, rural, semi-rural. As said, you don't need much. As a Buurtzorg model, you just need the people who can do the work, and the back office can be anywhere. So it's and that appeared to be right. So there is one director in that remote area, and that's it. Furthermore, it's just like you have 3 teams at the moment. It's not very big, but it's a really positive experience. And one of the things we found is community feeling, engagement is very strong in the more out of city areas, and that is perfect for the Buurtzorg model. And the other thing is those places hardly been served before, and suddenly there is now a provider who can provide those services. So that is really heartwarming, very rewarding work to do. And also the elevated payment for NDIS because of the remoteness, also helping to overcome the downside of things. So despite the neighborhood approach, distance can be still crippling. It's not still the distance are further out, but also seasons. Sometimes you can't get there anymore because roads are washed out or whatever. So you have all those typical things that you have to deal with in the more remote areas. The other thing is difficulty in finding suitable staff, and also most employees often have little experience in working in a formal working environment. Because in my aged care NDIS, it's you need to know stuff about. So there's some structures in place and incident management and complaints handling, all this kind of stuff. If you're not used to that, that is something you have to educate and train more. Also for the local workers, a small community effect, you can't escape. You see your clients at the IGA, you see, it sometimes I feel right, I can't escape. So I'm always busy with work. And if you look at team health, that is an issue you have to collectively address. How do we deal with that? And the other thing, the participant consumers have to be educated too. If you've never been served before, and also is choice and control, what does it really mean? How do you deal with that? So it's all right, I don't like you, you're out, that takes it doesn't work like that. It's building up relationships, and it have to be from 2 ways. But for a lot of the clients, it's new. So also you have to educate and going through the journey with the clients, and that will take time, and you just have to take the time. Also, we made some adaptations to the model. So we also have a bit of we call it Buurtzorg Light. That's not fully autonomous yet. We put in, like we call it, a coordinator to make sure that it's about educating clients, also educating the front line but things need to happen. Some things can't wait. So you have to be compliant. So it's not a fully fledged Buurtzorg autonomous team yet, but the goal is there. So it's more like a transitioning, what we call it, to a Buurtzorg way of working. But the other thing is, for example, 5-0. Living in West Australia, where 5-0 is very prominent. What we tried is for allied health clinicians. Very hard to get there in the remote areas. So we did with telehealth, but also with fly in, fly out. For example, 7 days on, 7 days off. They tour around for 7 days, and go back again to for example, Brisbane. And surprisingly, that works very well. It is so. It's also new for Buurtzorg, but let's try it. How does it work? And it really works. Very good. And don't forget, keep it small, keep it simple. We often end with this slide because it's part of our philosophy, and it's so hard to do this. This is the end of my presentation. Perhaps a lot of information in 35 minutes. But I hope that I could have given an overview what it comprises, the internal mechanisms, and what we're doing here in Australia. So thank you very much, and I'll give the word back for Q&A.
Thanks, Arnold. That's fantastic. And I have been, I guess, triaging a couple of questions in the Q&A as well as you've been going through. So anyone who has any other questions, please feel free to enter them into the Q&A at the bottom of your screen. You can just type them in. One question that has cropped up, Arnold, is about students, and I hope you don't mind, but I was mentioning that you've had health profession students involved in the Buurtzorg model in the Netherlands, but not in Australia as far as I'm aware. Is that correct?
We have some students at the moment. So we have 2 enrolled nursing students who are in the final year. So so that is not big numbers yet, but that is happening. Yeah, it's also having a student that has some responsibility to. We have to provide time to the person. Since we're a bit small, we have to be careful. Yeah, with that.
And so those enrolled nursing students are in Australia, or is that?
Yeah, they're in West Australia. Yeah, they're.
Yeah, fantastic. That's great, because that was one of my reasonings for wanting to get you to come along and speak today. Was we do similar kind of role, but we use students. It's called service learning, and so the students are supervised by a qualified practitioner, but the students themselves are delivering the care.
Yeah.
I just had a couple of other questions, but another one that has come up in the Q&A. I'm not sure if you can see the Q&A, Arnold, but there's a question about what clients are charged in terms of fees.
Yeah. With NDIS, it's pretty simple. For the lower end of the scale, we just follow the NDIS price guide. For allied health, we don't charge the maximum. For example, I think $204 an hour you can charge if you charge $180. So we try to be reasonable in that regard. We're not registered for my aged care yet, but we follow the market into the fee for services. And to make it simple, sometimes we just follow even the NDIS price guide in regards to that. So we don't charge admin fees and those kind of things. So it's pretty straightforward.
Right, thank you. I'm particularly interested in the people that you recruit, and I'm very interested in the kinds of I guess qualities and skills. What are the things that you look for to recruit into the teams that are providing the direct client care?
Yeah. Value-based recruiting is one of our things. So we look at the right character. So if you in the support work, the minimum for us is Cert 3. If you don't have Cert 3, but it's right, you have all what's important to us in value-wise, and also your ambition. We enroll you in a Cert 3 program, which is paid by us, and you get time for us to do that. So we have about, at the moment, I think 4 people in the Cert 3 certification at the moment. So that's a minimum side of things, but for us the values and also what we call the entrepreneurial spirit, it's very hard to detect that. So it's a bit of gut feeling too. And the teams are responsible basically for finding their own colleagues. At the moment, of course, we're in the early stages of the organization. We started September 2020. In the beginning, we did, as a back office, we did basically everything. We were recruiting people because we didn't have anyone, but you can see now we're growing, that the teams, that's all right, we need, for example, a male person who can deal with people with a mental health condition, because we get specific requests for that, and they find people, and we assist. And the only thing what we do is the teams and the coach will have a look at it too, because you tend to select people who are a bit similar to you, so we don't want monocultures in a team. So the coach will have a look at that, But if the team say, right, we want this person, we'll onboard them. So the formal side of things, the HR side of things, will be done by the back office. So it's, but we train the teams a lot to be able. If you never recruit people, how do you do an interview? Some things you can't ask, so they need to know that. So in the beginning, we did the coaches and I did, for example, the interviews, and then we became the coach and the current team members. So you can see it progressing. That it will, in the end, the team will do that.
Work it out. And all disciplines that you have working with you, so nursing and all allied health, are they the kinds of people that you attract to the roles?
We don't have all disciplines yet, so we're relatively small. We have 3 teams in West Australia and 2 teams in Queensland, so it's all modest size. So, but yeah, we have some allied health. So we just hired another one who starts next week after Easter. So that's fantastic. Support workers, and we have a couple of enrolled nurses, and we now have also a registered nurse. So that is basically the flavors we have at the moment. And people experience with mental health. Autism is a big thing in West Australia. At least we see the demand to do it properly. So it's we did a couple of very good jobs apparently, and you can see word of mouth is now starting to happen. So we're starting to recruit more people. Yeah.
And I was going to ask that actually, just in terms of, have you got some examples of how the Buurtzorg model has had a direct impact on client care? Have you got? It's always nice to hear good news stories. So is there anything that comes to mind?
Yeah. We got a couple of good news stories. Sometimes you don't want to speak badly about other providers, but unfortunately is that what you get compared by it, and that is even we had a client that has already two providers. It was an aged care client, and basically we were asked to do certain shifts of that, but we're not my aged care. We said no, I pay it in privately. And and also the family was so happy that we were getting involved and the difference it made to it. So it's and we started collaborating with the other one. So it was a really positive experience. So it was because we were a bit alright. We felt a little bit uneasy to walk into while 2 other providers were doing the things, but it was a really good experience. Really good feedback from it. I think the general feedback we get is the consistency and continuity of care and certain people apparently are attracted to the model, and the fact the decisions are made there where it's happening, and so there are no permission-driven things. If they see something, they can act to it. So the proactiveness, that is what apparently is very visible apparently by the clients. So there's action, and there's good action, and there's good support, and also the fact that how we deal with the environment, the holistic care element. I haven't discussed it now because of the time, but the holistic care element that you can see that is so important to bring that to the table.
Yeah. And so that true patient-focused care, I guess, seems to be at the core of what Buurtzorg are all about. Is that the care that's delivered is determined by the client or their family, their immediate family, and then yes, like you say, so there's an individual care provider who is there and is able to support across all levels, not just. It's not a case of, oh, well, you've got some issues with speech, I'll get the speech pathologist in. Yeah. It's more about being able to provide that support as immediate, right then and there, kind of. Yep.
Yeah, and also working together with other providers. The example what I just said in the beginning is that we're already two and specialized and non-specialized, and being able to collaborate. So that is important. And we try to get out of transactional. We're not transactional. The fact that, for example, NDIS and also My Aged Care, you have to bill per hour, whatever what you do, doesn't matter. Doesn't mean that you have to act like that. So it's the building up relationships, and some things are just not billable. And we say also do the stuff, don't think too much about it. Just do what you think is required and what's necessary at that moment, and sometimes a little bit less and sometimes a little bit more, and that's fine. You get your dashboard, you think, right, now we're getting now really out of shape, or you were a bit too billable almost. So we forget about the relationship we also have with the carers or the family, or we should reach out more to the public. We're in the community. So it is that kind of thing. But the fact that they have time to do that and not thinking in terms of transactions, that is a big difference in the psyche of the teams, and also how they relate to the clients.
Yeah, fantastic. And then there's just a comment here saying that it's such a refreshing model. It empowers people when we receive the healthcare. So it really is that empowerment model of, and like I said, really patient-focused care, or client-focused care. I hate to harp on about education, but I have to be honest, that's my area of interest. In terms of the education and training that Buurtzorg provide to the staff, could you give us a bit of an overview of what kind of training you provide?
Yeah, it's good to know that every team has a 4% budget, we call it. So from the team budget, the revenue the team receives 4%. They can spend to training and education and seminars, whatever. It's to the team. So spend it wisely, but we don't want to know, basically. So we know to do a certificate, and it's all HR side of things, but it's to the team how they want to spend it. So that is for the ongoing lifelong learning element. From the back office, we assist with things. If things changes in the NDIS or My Aged Care landscape that have to be disseminated, the information and the knowledge, so that's extra training. If you're bigger things like, we have now someone who is an enrolled nurse and right, I like to do a course, I want to continue in being a registered nurse, we support that. That's too big for a team, but that's then something for the total organization, right? Yeah, we like to have more registered nurses, and you put your hand up, and we'll take it on. Maybe we make an arrangement financially in time or whatever. So education, lifelong learning is very much appreciated. Yeah. So knowledge, we see that from a knowledge economy perspective, and to again. Sometimes the belief that cheaper people makes the system cheaper. No, we don't believe that. We go in the other way. So we elevate as much as we can the whole team members.
And it's probably why you have such a low staff turnover rate as well. If you're actually investing not only in the clients that you're caring for, but you're investing in the team and your own staff, which is really attractive. Yeah, fantastic.
Yeah, that's very important. Also, no strings attached. So you don't sign up, right? We do this course, we pay for it, and I have to stay for 2 years. We don't do that. If you leave immediately, then bad luck for us. But we don't do that. So it's no strings attached. We try to support that. And Buurtzorg always done it in every country, and surprisingly, perhaps for some people, but it really works really well. So people in general tend to do the right thing.
Yeah. Fantastic. Well, thank you very much, Arnold. It's been really interesting hearing about the model and how it's being developed for the Australian context and the Australian rural context. I think I know this webinar will be recorded, and so will be made available on our website, and the details are there. Arnold, I just also wanted to check if anybody has any other questions or would like to talk to you further. Are you happy for your contact details to be forwarded to anyone?
Yeah, definitely, no problem at all. So my email is available. So please, and my telephone number too. So please contact me. That's fine.
Yeah,
please do.
lovely. Thank you very much for your time. And yes, we will keep you posted as to what might be possible in Victoria. There's always some healthy competition between states, so
Yeah, I know. I
it
find that.
would be lovely to see what Victoria might be able to set up in comparison to Western Australia and Queensland. So thank you very much for your time.
Beautiful. Thank you very much, and thank you all. And yeah, hope to see you in Victoria.
Yes, yeah.
One day again, when we can fly freely.
Absolutely, absolutely.
Okay.
All right. Thanks and good night.
All right. Thank you. Bye-bye.